Hello, everyone. I'm sitting here sending text messages out, and I realized I was just texting Alicia. So welcome, everyone. Let us know where you're listening in from. Lots of snowy places, cold and snowy PA. I'm sorry to tell you, I'm in warm Florida, although it's cold for Florida, but don't hate. What about you, Alicia? You got snow on the ground?
I still have snow on the ground, and the weather is cold, but it's not the bitter, bitter cold that we had at the first of the week. We are we're past the teens. It's
So
too cold to snow.
Yeah. So tonight we got some good information to share with you. We'll just give it's not even 8 o'clock yet, so we'll wait a minute or two. So let's see, we got Margaret was the first one in. Looking forward to another informative webinar. Thank you.
And Amanda, we share the same, your last name is my maiden name. Cool.
Olson? Oh.
Witt, Amanda Witt. I'll just put her on the screen.
Teresa.
There you are, Amanda.
Newton.
Jenny's in Missouri, like me. Woohoo! Depending on what part she is, right? We could be close. Oh, yeah. Massachusetts, -1.
Yikes.
Yeah.
Southern California, they're probably a lot like us here in Florida.
Yes, there you go. Martinez in Texas. That much better weather in Texas, especially if you're from the neck of woods that I was at. It was back in West Texas and Southern Texas.
Yep.
So excited to see you guys, and thank you again for sharing where you guys are at. We really appreciate that. That makes us feel good to know that we're reaching people all over the United States. And just a little shout out to remember to tell your peers and friends about us and let them know the services that we offer. We're predominantly word of mouth. So,
and we have to recognize Alicia. She's sporting a new do.
Well, you guys, this is, I wanted a 1920s bob, and today I got one, and she straightened my hair, and my hair is no longer, it used to be like this when I was a little girl, very, very straight. But as I got older, and my white, anyway, so next time you see me, it'll be real, real short, but it'll be curly. I may look like, oh my word, I may look like, well, the red's almost gone, but I could look like Annie, or what is Bozo the Clown. It could be Bozo the Clown, guys. We'll see. Next week, stay tuned. We'll see what I look like next week.
I say it looks good on you, and
well, that was my shortest layer, so we'll see. I want it to be my chin, my little bangs. So we'll see.
Shirley Temple.
Yeah, sure. I wish I'd be like that cute. My sister's hair naturally curls like Shirley Temple, and this is what I would.
I never get on Facebook anymore, but I did today. And who's there? Alicia showing her bedhead.
Before I got my hair cut. It was a lot long. It was still short, but it was long.
That's funny. All righty. Well, let's get going here. So we've got 2 topics tonight. I'm going to be doing Pro-Fee versus facility outpatient coding. And Alicia's going to be doing coding complexities, documentation, modifiers, and rules. So let's see what we have here. So shout out to our interns, Kristen Estes and Tatiana Walker. They helped prepare our slide deck. So thank you, ladies. And if you're interested in joining our intern program, just go to cco.us, contact us, and you'll see the intern form. We're always accepting new ones now. Oops, we're not going to take a commercial break just yet. So let me switch to my slide deck.
And as you're getting ready to switch, Sandra, we'll make sure you know how to get the CEUs, but they are in the club. So we'll talk about that at the end.
Yeah. Basically, we've been doing it this way for a while. We share, we do live streams pretty much of almost everything, but the CEUs are reserved for our club members. So if you want to be a club member, go to cco.us/club to join. You can check us out at the Academy, cco.academy. That's where we, give you the CEUs when you're a club member, where we talk about them, where we have conversations with each other. I just answered a couple questions today, and our interns are really good at jumping on and helping answer questions. Pretty detailed one. And so with club members, we really make sure that their questions get answered. If you have an op report or an E&M note that you're struggling coding, let us know what you think it should be. Redacted, of course, and we'll take a look and let you know if we agree with you, and if not, why. So lots of people use us for tiebreakers. My provider says I should code this, but I think it should be that. What do you say? And then we give them the support that they can go back to the provider and explain it. So, all right. So pro fee versus facility outpatient coding. And this little diagram is showing on the top, pro fee is related to the professional, meaning the provider, the physician. So it's called professional services. And then the claim form they use is the 1500 form. Whereas if you look down below, the facility or the hospital is billing for the technical or facility services, and they're going to use the UB04. I'm so trained, I want to say UB92, because that's when I first started teaching, that's what we had, but now it's the 04. And those two together go out for claim submission and payment. So today we're going to be talking about what are those differences, because many times we have a CPC certified coder that has taken that certification and they've seen the COC, the outpatient credential, and they're kind of curious, well, what are the differences? Because they're still using the CPT manual and the ICD manual. So what makes it different? Because maybe you've seen some jobs in outpatient that you shied away from, but after tonight's information, it might help you decide to maybe apply for a job like that. So it's going to be a focused breakdown on a critical topic, the distinction between professional fee and facility outpatient coding. So whether you're mastering your current role or preparing for a certification, understanding the differences is going to be key. So for the left side of the slide, the pro fee coding, that's going to center on services delivered by the physician or a qualified healthcare professional. The foundation here is the accurate application of CPT and ICD codes, and that's going to directly impact the provider's reimbursement. And it's going to be based on relative value units, or RVUs. So this coding, you're going to really need to have good CPT accuracy, and the role often involves directly communicating with providers if you need clarification to have the best coding. Moving over to the facility side, it's about classifying the resources used by the healthcare facility. So they're not billing for, like, say, the E&M visit, like the professional service. They're billing for their resources, even if the physician provided them in a facility, but the facility is trying to get paid for their resources. Sorry, I just got my tea delivery. So the focus is in the facility side shifts to asset-based billing. So you're going to become proficient with things like revenue codes, charge masters, and grouping software like APCs and DRGs. Sometimes you might not really be doing the grouping or whatever, but understanding how your work impacts that helps it make more sense. So if you want to learn more, you can go do some research on DRGs, revenue codes, charge masters, those three things. And the claim form, the UB04, to see how it's different from the 1500. The compliance standards are a lot more stringent on the facility side. So coders rely almost entirely on the quality of the clinical documentation. They don't get to query the provider as much because they're not, right there and handy. So for a smooth transition to facility coding, you want to prioritize three things: the billing system. So master the UB04 form and the facility's unique billing rules. Now, you're not going to be filling out a UB04 form like the old days, but understand the fields and what information is needed on the form. So you can print a form and just look at it to get familiar with it and compare it to a 1500 form. The second key piece is grouping logic. So practice with APC and DRG grouping software to understand reimbursement mechanics. And then number three is documentation. You want to review compliance guidelines and recognize the reliance on thorough clinical documentation rather than direct provider queries. So by embracing these core concepts and utilizing specialized training resources like us at CCO, you are perfectly positioned to excel in the world of facility outpatient coding. And you have the foundation now. So let's build on that and gain some more confidence. So this next slide is, someone's saying refresh the page. Oh, they're telling someone else. Okay. All right, so this next slide, key differences between Profi and facility coding. We've got two columns again, Profi on the left, facility on the right. So now that we've established the core roles, let's dive into the key differences that truly define the two specialties. And this is going to be the essential knowledge that you would need if you're going to be taking, say, a certification exam. So the shift primarily centers on what is being billed and how it's being paid. So you're still using CPT, you're still using ICD, but the difference is what's being billed and how it's being paid. So let's talk about the claims. For Profi, the world revolves around the CPT code and the doctor's reimbursement via RVUs. But for the facility outpatient, the focus changes to asset-based billing, which requires mastery of revenue codes and the charge master. These codes classify the resources the hospital used, which is a significant strategic difference. The next is the payment logic. While Profi is relatively direct, facility billing introduces the use of complex grouping software like APCs and DRGs. These systems bundle services for reimbursement, and knowing how they work is non-negotiable for success. And then finally, the biggest change for many is documentation and provider interaction. In the Profi world, you often have the chance to query the provider directly for clarification, but in facility coding, you have to rely on strict documentation compliance and the thoroughness of the clinical record. Now, inpatient, you got the whole CDI thing going on, but we're talking about more like outpatient kind of facility. The detailed documentation is what you're going to have to rely on. And so your ability to abstract what you need from that is going to be critical. So mastering these core differences in billing, payment logic, and documentation is going to help you be more confident in either role that you're coding for. So the next slide is just continuing on those columns. To be successful, to bridge the gap between Profi and facility outpatient coding, you want to focus on three critical areas that you have to master. And the first one is the documentation and communication. For Profi, we're encouraging direct queries and discussion with the provider for code clarification. And you have more of a personal coding approach with the provider. Whereas on the facility side, you're going to follow more strict guidelines on provider queries. It's less direct interaction. It's more sending them like almost like a memo kind of query. And you're emphasizing adherence to facility documentation and compliance protocols. For skill set and tools on the Profi side, you're going to require detailed knowledge of CPT, modifiers in physician documentation, and manual processes and coding based on the physician notes. On the facility side, you're going to be looking more broadly, and you're going to include revenue codes, charge masters, and grouping logic. And also you're going to be looking a lot at the billing regulations. There's more of a digital workflow on the facility side, and a lot of encoder tools are used. Then the last point, encounter volume and complexity on the pro fee side. Generally, you're going to be managing a higher volume of shorter, discrete encounters. So lots of office visits, consults, whereas on the facility side, you're going to have fewer but more complex encounters. So you have your inpatient stays or their observation in the ER, and it requires extensive documentation and coding precision to get that facility reimbursement. So what are some important things to look out for when moving to facility coding? It's all about the revenue cycle. So you want to understand revenue codes and charge masters. Basically, a charge master, you want to think of it almost like kind of like a super bill is for the physician side. It's just like things they would check off that they provided, and it gets automatically coded. You don't need a human coder to actually code it. It goes into the billing system because, say they're in radiology and they mark off the procedure they did. They will often do that via a charge master. So facilities require proficiency with these, which represent categories of services and supplies, and it influences the billing and reimbursement. Then you want to be familiar with groupers. Facility payments often depend on grouping software like APCs and DRGs that assign payment categories based on sequence of codes. Strict documentation compliance. Facility coding follows detailed compliance guidelines. Incorrect billing can lead to audits and penalties. Then going from pro fee to facility, there's less emphasis on direct provider queries, which we just talked about. And you're going to be relying more on the actual documentation. And then finally, for payment coding and accuracy impact, while APC reimbursement can sometimes tolerate near correct CPT coding, pro fee coding demands nearly 100% CPT accuracy. So there's a little more wiggle room on the facility side because they're billing more for the resources, whereas professionals that's what the whole CPT book was designed for, was to report those professional services. And that does shift a little bit in the coding and its impact. So tips for transitioning: study the UB04 form and facility billing rules and understand the different claim forms and billing processes. Learn revenue codes and how they map to services. It's critical for asset and resource-based billing. Third, practice using the grouping software. Familiarize yourself with the systems that determine reimbursement. I like to think of it like, I don't know how far you went when you took math in high school, but if you got up to like calculus and there's these formulas, you could be good at it and just plug in the formula. But once you understood why the formula worked, it made it go so much easier for you. At least it did for me. I really, really struggled with calculus and went for extra help. And when I finally got the formula, everything clicked. So that's what this is like. When you understand how your coding impacts and gets grouped differently and how it affects the ultimate money, that really makes you understand how important everything fits together. Then there's review and compliance guidelines. The documentation requirements because they're different in both settings. Seek training and materials and videos focused on facility coding if that's the world you want to get into. We have a lot of videos on CCO, and we have a course for the COC prep. And engage in sample coding exercises. We're a big fan of taking timed practice exams for certification exams, but the more practice you can do, the better. And then join discussion groups like at CCO.Academy. So when you are going over a case and you need some help, you've got some buddies to help you. And this is just resources. Just find some resources. We hope that we're your resource of choice that you like to pick. So come to cco.academy. And then just to sum it all up, Profi coding focuses on coding for the individual provider, and it's based on reimbursement for relative value units, which are tied to the CPT code, and requires detailed CPT knowledge and provider communication, whereas facility coding centers on coding the use of hospital resources with the focus on revenue codes, APCs, and DRG grouping, and they use the UB04 claims. So the key to success in facility coding is that you must learn facility billing workflows, revenue codes, grouping software, and strict documentation standards, and take advantage of any specialized training related to facility coding. I will say, when I first took the COC, I misunderstood because it was considered hospital. So I was all prepared for inpatient hospital coding. And I'm like, this just feels like a CPC exam. And it very much was, because the CPT coding is very similar. But there were some questions related to DRGs and APCs, not that many. So if you pass the CPC, you can easily pass the COC. We have a COC review blitz that you could actually use to just kind of get a nice review before sitting for the certification exam. So, any questions on the difference? There's a little redundancy there, but repetition for emphasis. All right, I don't see any questions.
I don't see any questions either coming through. I was watching the chat.
Yeah, well, this was a shorter one. You got the long one, so.
Oh.
So do you want to drive your own slide?
You know what? I am on just one monitor.
Okay, I can do it.
So yeah, I think have you do it, because you guys forgive me if I lean in a couple times to see. But
yeah, Alicia's taking care of her dad who is recovering.
Knee replacement on Monday. Yeah. And so I'm at his place, and I just, usually Laureen and I have this, we look like we work for NASA or something. And Sandra makes a good point. I do Profi and it sounds so different. It is different. And yet if you do one, you can do the other one. The transition's pretty easy.
Yeah.
But it is a different hat. So
yeah, nuances.
Used to it.
All right, take it away.
So we are going to look at the coding complexities, documentation, and modifiers and rules. This is really exciting because it first of all, heads up to the CDI class that we're getting ready to start. This is where that information shines. And Lorraine and I have been talking for quite some time that, risk adjustment was very, it was in inpatient before it became involved in outpatient. Now the big thing is CDI, because we do have the help of AI. We have a lot of physicians that are coding for themselves, but they have to be audited and educated on the documentation to make sure that one, AI picks it up. But even before AI was around, the documentation is key to making sure you're reimbursed properly. And so really mastering medical coding is all about documentation and compliance. So understanding the nuances, we're going to look at the modifiers, pair rules, and evolving guidelines. As we move on to the next slide, we're going to just highlight some of, first, the documentation nuances. And the first thing is having a complete clinical note. Now, what happens is they create the note right after they take care of the patient and sign off on the note. It really doesn't get officially coded and billed out until it's been signed. That's with electronic documentation and stuff. It's so much faster than it used to be. But coders, they really rely on that clear documentation for the diagnoses as well as the procedures. But the things that we have to remind the clinicians about is severity, laterality, timing, making sure they document acute versus chronic when that's applicable. So an example here is if you have a patient with CKD and hypertension, so with that, it makes a difference because it changes the code. The hypertension code changes, and that we know as a coder. But what we may not remember, or the clinician isn't thinking about, is staging the CKD. Now, in the past, there was CKD3, and now we have CKD3A and B, and they don't always know that the code set has changed and allowed us to document at that specificity. Also, what services were actually rendered, the interventions that were done, the patient consent, duration, modality, and telehealth. Now, the rules change on telehealth pretty frequently. Right now, as of the time we're doing this webinar, telehealth is more or less paused versus the format that we had available to us with COVID, but it's still being used. Make sure that you're teaching your physicians to avoid ambiguity. And let's see, I said that really fast, but I pronounced it incorrectly. Don't worry about that, though. Vague or incomplete documentation is really going to result in undercoding. You're going to get denials, and then worse, it's going to show up in your audits. So as we go on to the next slide, let's look at the role of accurate coding. It really is important to reflect the true patient story. This ensures that you've got compliant reimbursement happening, but it's not just the codes getting paid. Why do I say all the time? We code for statistical purposes. It happens to be a convenient way to get paid. And that's what this third bullet's stating. It supports public health data and quality metrics. If we don't have coding done at the highest specificity, meaning translating at the highest specificity with the documentation we're given, then we're skewing the metrics for the patient and the patient population. So it really is more the numbers. It's about a language that is required for payers and regulators that actually happen, the regulations that happen in care. And as we move on to the next slide, we're going to look at the documentation as a foundation. If it's not documented, it wasn't done. We've been saying that for ages. If you get into this industry, that's one of the first things you learn. And then coders must accurately match the documentation. We are translating. We're translating the documentation, which is like a medical language, into a code set so that it could be tracked for statistics as well as and being paid, right? It's as simple as saying if a person has a multiple lengthy diagnoses that have lots of acuity and laterality and so on and so forth, we can't be writing that out or even typing that out. We narrow it down into characters. So documentation is what drives the coding, but without specific details, you can't legally or ethically assign the codes. You can't just say the patient has cancer. We need to know what type of cancer it is, whether it's malignant or benign, which would make it a mass, or where it's at in the body, and laterality and all that stuff plays a part. Just cancer alone doesn't cut it. Moving on, we're going to see that common documentation gaps that you'll get used to seeing is missing specificity, site, laterality, and severity. Now, this isn't just, don't think of site alone. Some other areas of diagnoses that have Severity would be any types of depression, mild, moderate, and severe. So for severity, that's your key terms. Is it mild, moderate, or severe? Is it right or left? And what body part is the diagnosis on or affecting? The lack of time documentation. With the ability to document for time, a lot of the E&M is based on time if it outweighs the medical decision making. So the fact that the physician had to spend 45 minutes with the patient outweighs the fact that the patient's diagnosis was relatively low medical decision making. But if that patient had a cognitive problem, or they had say they were autistic, and so the doctor had to explain multiple times so they could feel comfortable, or they had to bring in tons of data from an outside source because the patient had moved. All of that plays a part, and they get paid for that time. Ambiguous diagnosis, infection. Well, where's the infection? What's the organism if you know it? If you don't know it, what are you doing to find out? What tests are being done? How severe is the pain on a pain scale from 1 to 10, right? The little smiley faces that turn into frowns. Is it chronic or is it acute pain? Things like that. We need to know the details because we're able to translate that. And then cloned or copied notes, that's kind of a cardinal sin within our industry. It is okay to copy and paste lab results into a note, but you don't want the same HPI for the patient for the next 5 encounters. And this happens both in outpatient and inpatient, subsequent hospital visits. Sometimes if the patient's in the hospital for 10 days, you see that cloned documentation. So clarity and detail are critical, especially when we're dealing with risk adjustment or procedural coding. Next, strengthening the documentation. What can we do? What can we do to encourage and help our clinicians document better? Real-time charting, chart right after you get done seeing the patient. And now with them carrying around laptops, they're able to chart in real time. And one of the ways that AI has been helpful is they have AI scribes, which pick up those key words and also prompt the physician. Use standard templates and checklists. That's every EMR system has those. Include medical necessity rationales. This can be done with auto texts a lot of times, and cross-link diagnoses with procedures. So if a patient is having an appendectomy, then of course you better let us know that they have appendicitis. You'd be surprised when there's a gap sometimes in those simple things. Providers are going to document, they should, as if explain the visit to a peer reviewer. If they think in that process, then by all means, you'll have better documentation. Moving to the next slide, we're going to see that the CPT modifiers are extremely important. So what's their purpose and impact? The service will, with special circumstances, is when a modifier is going to be applied. So you think anytime you have a patient that's going to have a procedure done and more work is necessitated because the patient is obese, they open them up and there's lots of lesions that they weren't expecting, or there's a time delay and complication because of the patient's blood pressure during a procedure. Or even if we don't talk about procedures, what if we're seeing the patient and they come in, they sit down with the physician and they say, oh, by the way, I know I'm here for you to look at my toe that I stubbed last night while getting up and going to the bathroom, and I'm diabetic and and vascular insufficiency and stuff. So it's really important. But since since I'm here, can you look at my ears, because I'm pretty sure my ears are plugged up. And so why is the patient being seen? They're being seen because they have the possibility of a diabetic foot injury, and but the physician says, let me go ahead and lavage your ears, clean your ears out. That's a separate procedure. How are we going to distinguish that the physician is doing a procedure at the same time that they are looking at that toe? The ears and the toes don't relate. There's a modifier that indicates that. In addition, things like Modifier 95 and 93 for telehealth services, Modifier 59, distinct procedural service. This is commonly used in the ASCs, outpatient surgeries and surgeries. Modifier 25 is that one that I used an example of. The patient comes in with a diabetic toe injury, yet while they're there, they might as well have their ears looked at, and they get their ears cleaned out via, using a tool, not just the lavage. That would indicate a modifier 25. Really, the impact is that we want our physicians to get the proper reimbursement for the work that's being done. And those modifiers tell the rest of the stories and prevent denials, as well as things like bundling issues and duplications of bills that are sent out. As we go on, let's look at those modifiers a little bit more. They're always a 2-digit character. They are in the context that we use them in CPT. There are some Hicks-Fix modifiers as well. Really, the heads up that a modifier is going to be applicable is service alterations, separate procedures, laterality, or repeating something that is either a routine repeat or is an unexpected repeat of a procedure, like going back into the OR because the patient obviously had bleeding after a procedure was done. But the modifiers tell how and why the procedures are different from what is standardly expected. So you go in and you take their appendix out because they have appendicitis. The appendectomy is expected. Once they get in there, they kind of peek around because that's just standard practice, and they notice a mass that they didn't know that was there, and so they decide to biopsy it and stuff like that. That wasn't part of the planned procedure, so for that extra work, we need to be reimbursed for it. Sandra asked, do modifiers go on plain film images? I'll get back with you on that. Let me look that up. So moving on with modifiers to the next slide, we're going to look at some of the most common ones. Again, modifier 25, the term for that one, the definition is significant separately identifiable E&M. Now, the number one thing that usually happens, especially in pediatrics, is they come in for their office visit and they decide that it's time to get their flu shot, or they give them an injection. Maybe they give them an antibiotic injection. Maybe they give them a steroid injection because they came in now thinking out of season. They come in with poison ivy from all over their arms and face and belly, and the doctor says, I'm going to give you prednisone, but let me give you an injection to speed this up. And maybe they even give them an antibiotic. 59, distinct procedural services. So this is a new complaint after surgery. So the patient goes in, they have the surgery, and then something happens after the surgery that the physician has to address that is not about the surgery. So it's one thing if the patient has an infection, that's all bundled in and part of the procedure. However, and you need follow-up care within, like if they open you up, it's like 90 days, global days. But if something happens in between, then we're going to absolutely add a modifier 59. Bilateral procedures, the example here, they're doing an image of the patient having arthritis in the knees, their knee keeps swelling up, and they do a steroid injection, but a lot of times it's one knee, not both. but sometimes it's both. And they say, okay, let's go ahead and give you a steroid injection in both knees. Well, the procedure and the code is set up for only one knee. So if you send that out on its own, they're going to say, well, you already did one knee. That's a duplicate. And so modifier 50 will indicate, hey, we did two. 59, distinct procedural services, 2 unrelated lesions excised at the same time. Now, if the lesions are, say, on the same arm or are on the face, then that's one place. But if you remove a lesion on the forehead and you also remove a lesion on the left hand, that's distinct procedural services. Modifier 24, unrelated E&M post-op, new complaint after surgery. Say the patient had a procedure done and they come in their follow-up visit. They say, yeah, I'm doing really good. My pain's under control. But guess what? I've got this rash, this crazy rash. And come to find out, they're allergic to the pain medication. Well, treating them for that rash, that's, say they have yeast or something, that's not part of the procedure that was done. So they get paid for the additional work. Laterality, left and right. So if they have a procedure done on the example here for the eyes, if you're going to have cataracts removed, you're absolutely going to indicate left or right eye is being done. Really know that each modifier changes claims, and misuse can lead to denials. The lack of using one will lead to denials also. As we go on, the next thing we need to look at is the 20 most commonly used CPT modifiers. Now, if you don't have these under your belt, then this is not hard to learn. Now, we have a lot of additional education on modifiers. Lorraine created this fantastic modifier grid many moons ago. That's extremely helpful. But these are the ones that probably you'll have most of the time cross your desk. 22, increased procedural services. I went in, I was doing one thing and I had to do more. Reduced procedural services. I was going to do something, but I had to stop because this happened. Surgical team is used whenever you have a transplant. There's a whole surgical team. And I don't know if you guys know this, but if a patient has a kidney transplant, a lot of people think, well, they take the diseased kidney out and they replace it with the new fresh kidney, right? That's not what happens. There's 3 teams involved in a renal transplant. The first team harvests the organ. The second team makes a pocket in the body of the recipient to hold the new organ. And the third team actually implants the organ. So when a person has a kidney transplant, you then have 3 kidneys. Because even if your kidney works only 10%, the damaged kidney or diseased kidney they leave it in because that's still 10%. You maybe didn't know that. 79, unrelated procedure by same provider. Now this is different in the surgical team or the doing like a 70. Let's see. Well, I'll hit it in just a second. Unrelated procedure by the same provider means he went in, he was going to do one surgery and ended up having to do another one at the same time. Okay, now these E1, E1, 2, and 3, that is your fingers or your digit. They have them for fingers and they have them for toes. So E1 is the thumb, E2 is the pointer finger, and E3 is your tall man, middle finger. And so that if you're having a procedure done, say you broke your thumb, it'll be an E1, the procedure that's done. Going to the second column, top, Modifier 25, we've already discussed that. Modifier 53, discontinued procedure. Okay, that's the one I wanted to tell you. Reduced services versus discontinued procedures. These are always on testing questions, and you need to understand the difference. The 152 is we reduced the service of what we were going to do, and because let's say there was a test that was done on the kidneys and you have two kidneys, but this person only has one kidney because they were born that way, then it would be reduced services. I'm only doing the test on one kidney because the patient only has one kidney. But the code is for kidneys. Now, discontinued procedure is uniquely different. I was going to do a whole EGD scope from the mouth, go into the stomach, and then get farther into the past the stomach. And we started, and the patient had, we got in, started looking at the back of the throat, the larynx, got into the esophagus, and they had massive esophageal varices, and one ruptured and it was bleeding. So we stopped. So they discontinued the service that was planned. You code for the planned service and put the modifier 53 that you had to stop because of the welfare of the patient or for whatever reason. So you can see how that's different than reduced. Now, 76, repeat procedure by same provider, and then modifier left and right. Go up to the third column. Top bilateral procedure is always 50. Distinct procedural services, that is when we have two different procedures at separate sites. So we are, again, we're removing a lesion from the forehead and the hand. Repeat procedure by another provider. They won't pay for a repeat procedure unless it's staged or something, but they also expect the same provider to continue care. It's continuity of care. So if there's a reason that another provider did the procedure, then we have to let them heads up, or the computer will reject that. Modifier 51 is doing multiple procedures. Now, these are planned procedures. This isn't like, 25 unexpected E&M. No, this means that we have to do multiple procedures to get the patient taken care of, like a appendectomy and doing a hernia repair at the same time, doing a appendectomy and a cholecystectomy at the same time would be that. Whenever you have two surgeons, that's a 62. Now, I also work with a teaching facility. That is a nuance. But when you have two surgeons, you have co-surgeons, right? And the documentation has to be very specific. Who's the attending? Who's, it's like primary and secondary. What are they doing? What portions are they doing? They identify what they did and the other surgeon did. But there's often a time that you need two surgeons. That is not the same as 66, a surgical team. This is one, say, we're going to go in and repair a facial deformity. And so we have to remove the tumor, and then plastics comes in and repairs the face or does a flap procedure. That would be two surgeons working on the same patient, but for separate reasons at the same time. Return to OR for related procedure. These are things that are staged for 78. And the example they give is patient goes back to the OR for post-op bleeding, because these are kind of bundled. You have a global package when patients are in the hospital. And then we did E1, so go down to technical component. This is an interesting one that we want to be very aware of, and this has to do with who owns the equipment. What are you doing? Are you doing the service as well as reading the imaging and giving a report, or are you just reading the imaging and the report versus doing the whole thing? So as we move to the next slide, we're going to see that modifiers, if we misuse them, we have a lot that will cause risk. So overuse of the biggies are modifier 25 and 59. Why? Because it allows for more payment. For one thing, it says that you're doing more work. Well, then you better be able to prove it in the documentation. And these are what auditors, they trigger our audit. They trigger an audit if you are out of the benchmark for the being used with peers of your own specialty. Every single time you use a modifier, it has to be supported by the documentation. If you don't, then you're going to get claim denials. And it's not just denials. You may get audited and have to do repayments. So payers pay very close attention to modifiers. They analyze the trends. Their consistent overuse is a red flag, and compliance will get involved internally, because you definitely don't want to have to repay large sums of money. Okay, now we are getting close to wrapping up, I think. What's the next? Yes, the power of medical necessity. Every service has to be medically necessary. So remember the patient that came in because they stubbed their toe, they're diabetic, which could be very problematic, and they also had their ears cleaned out. Again, that's justifiable. But let's say the doctor looks at the toe and said, you know what, we need to get an x-ray. Okay, that's not a problem. So they get an x-ray and he says, there's no fracture. But you know what, I think we need to put a cast on your foot. Well, what's the medical necessity of having a cast put on your foot? If you didn't have a fracture or some other reason, that's not medically necessary. If you go in and you have appendicitis, they do an appendectomy and they say, you know what, while we're in here, we're going ahead and take your gallbladder, just because we're already in there, and you're female, you're 40, you're fat, and you're fertile. So you're probably going to need to have that taken out within the next few years. So I'll just go ahead and take it. That's not medical necessity. You're not allowed to do that. Documentation has got to always answer why, and why, and I started to say why and what for, but that's really the same thing. Why are you doing what you're doing? Can you get by with not doing it? What is the medical detriment to the patient if it's not done? Things like that. And the ICD code, the diagnosis, always has to match the CPT or the procedure code. So if we go in and we do an x-ray on a toe because there's a possible fracture, and then say we want to do a Doppler study for pedal pulses to make sure, because they're diabetic, that we have good pulses, that's fine. But just because a person stabbed their toe, if they don't have any other indication to have a Doppler study done, that's above and beyond, right? So if it's just a stubbed toe on a healthy foot, a possible break, versus a diabetic foot with possible insufficiency, then that's completely different. They've got to match. Medical necessity is what drives payment, but without rationale, payers are going to deny it. And even if the services was performed, they won't pay it. But just because they did a Doppler study doesn't mean you're going to get paid if you can't prove there was a reason to do it in the first place. All right. So as we go to the next slide, we're going to see that the variation in coverage across payers really is important to understand. Now, this is something that you learn internally. The billing stays on top of this, but so do the analyst and the authorization people, because this is a behemoth of change. So when you navigate the complexities of Medicare, Medicaid, commercial insurance rules, telehealth, again, we saw a huge change in that. Behavioral health, all of them, preventative services, there are rules, like preventative services, having annual wellness visits. You cannot have them, they have to be more than 12 months apart to the day, or you're not going to get paid. Whatever Medicare does, everybody else eventually follows. So that's kind of a rule of thumb to remember. So the services and the procedures that are being paid now may not be paid in the same way a year from now. Medicare can have specific rules for telehealth, of course. So does Medicare for different significance of state programs. Remember, Medicare is federal, Medicaid, state, individual. If what I was able to do in Texas, if I had a Medicaid patient versus a Medicaid patient in Missouri, completely different. Because the states decide on their own. But commercial insurers, they, for the most part, are national as well. And they often have some unique things where they have incentive programs, where they want certain, maybe they want certain preventative things done. You can have a mammogram every year if you're a certain age versus having to do it every 3 years, and they'll pay for it. But I'll let you look at the examples and variations, but ultimately the implication for coders is that you have to check the payer guidelines from each of these services, or you could get claim rejections. Now, if you work in a facility, they have people that do this, and maybe you're a part of that team, authorization team, especially analysts. It's an exciting role to be in, but you have to be on top of that, especially if you are in private practice. As we go to the next slide, we are going to see some of the main ways to check payer specific rules. Medicare, you're going to look at the NCCI edits and LCDs. For example, Modifier 59 guidance. Medicaid, state specific. If you work remote, you could be familiar with the state you live in, but if you work for another state, that can make a difference. Bundling for prior auths, that happens a lot with Medicaid. And commercial, they have contract rules. So just because, say, you work for a university teaching facility and versus a private practice, they could have different contracts with these entities, and that will affect how you get paid or if you get paid for certain services. This example is preventative versus diagnostic lab tests. Different payers always means different rules, and always verify with the local LCDs or policy manuals. Stay on top of that. That's what we're required to do in our industry. That's why we read the journals and we stay connected. We do that at CCO. We can let you know when things have changed and heads up for situations. Moving to the next slide, which I think just about wraps this up, if I remember. Oh, wrapping up with bundling and unbundling. Just know that bundling is two related services paid as one, and reporting separately only if justified. So bundling would be things that are like global days, and unbundling is, say you're outside the global days, then you get to charge a regular E&M after a procedure. Example they are giving is an excision closure usually is bundled unless closure was complex. So if a patient has a deformity fixed on a face, then when you stitch them up, that is all bundled in. But if plastic has to come in and do a flap, then of course that's a different, you are going to get paid for that. Coders also need to check the NCCI edits. The impact of correct coding is we don't want to have claim denials. We want to be reimbursed timely. We want our statistics to go out so that we can show our patient population. We don't want to have triggers for audits by misuse of modifiers. And a violation to payer contracts can mean you don't get your contract, you get dumped, and you definitely don't want to get dumped. Commercial is one thing, but Medicaid, Medicare means you'll almost go out of business. Accurate coding isn't optional. It is compliance and a financial safeguard. So it is something that we have to be aware of as a coder. It's just a standard in our industry. The evolving guidelines you need to be aware of. The frequent updates is the code sets are always updated every year. Compliance requirements, you've got to stay current for improper coding and maintain compliant with regulatory requirements. If you work for a big entity, this is always stayed on top of. There's a whole team that does that. Continuous education. We are always learning. I learned something the other day that I thought, I would know, and I was completely wrong. And it was wonderful to get knocked off my my pedestal and say, well, I didn't realize that. So coders and clinical staff could engage in ongoing training, have huddles, get together to remain familiar with coding changes and best practices. If you keep up with annual updates, every October 1st, ICD-10 is changed with the new codes and deleted codes. CPT and HCPCS, January 1st annually. And you review the CMS transmittals and AMA up and CPT updates, and encourage a routine review of codes changes for maintaining accuracy. Emerging trends, just heads up. AI assisted documentation is here to stay. I know a lot of physicians that are using AI scribes right now, and it's working well for them. They still have to sign off and read on it. I mean, it's not perfect. Telehealth expanded, and now it inflates and then it deflates. And the SDOH is social determination of health. Get on top of those, because that is being pushed heavily right now. Automation is going to be able to help us improve our efficiency, but there's always errors. And that's why CDI is essential, and auditing traits are essential for us to be on top of. Education and compliance programs, you want to make sure that you are doing internal audits all the time. I work for an entity where they do internal and external audits on all the coders twice a year, and once a year on all their clinicians, meaning the physicians and NPs and stuff. The OIG recommendation compliance programs come out every year, and they let you know what they're going to look at. And ongoing coder and provider training, that's why we get CEUs. And you can get that ongoing training with us at CCO. Education is really the best way to stay compliant, be proactive, not reactive. And again, that's why we are doing our CDI course. We know how important that is for the future of coders. Key resources: the AMA CPT Assistant, the AHA Coding Clinic, the CMS NCCI policy manuals, and the AAPC Knowledge Center are the biggies. Also the CCO Academy. Use credible current sources and don't rely on outdated PDFs or forms. So if you go out and do a Google search, it may not be the latest and the greatest. And also, I've done a lot of searches where they gave me, I asked a questions, they referenced sites, and they would give you like the AAPC Knowledge Center, but it's, like 6 years old because it's picking up on keywords. So make sure that you're getting the current information. That, I think, does that wrap us up, Laureen? I think. Oh, key takeaways: accurate coding.
Last one, I promise.
Okay, I kept thinking that they looked familiar as I went through them, but accurate coding starts with precise, thorough documentation. CDI, it's all about the documentation. And coders are educators now for your internal team. Wherever you're at, you are set on a high standard, and so you're often required to educate the clinician and other people. Modifiers are going to be essential. If you don't know the modifiers, then expect denials, because you don't want, or audits. Payer specific rules, stay on top of them. They change frequently. And then guidelines evolve, regularly requiring you to get ongoing education. I'm going to sit in on a one about hand surgery, and that's not my department, but I'm part of surgery, and I'm going to sit on that because I know I'm going to learn something. Tie it all together. Accurate documentation supports accurate coding, which supports compliance. That's the key. Those three biggies. We did it, guys.
Did it.
Yeah. I talk a little too much.
You're fine. No, you just had a longer one. And because we're using AI to do the outline, and the interns go and vet it and add the nice graphics, and sometimes there's a little duplication. So just repetition for emphasis. You're getting the points.
That's right.
A question came in for all right, a couple things. So the modifier grid that Alicia mentioned, I put in the chat a link to how to get that. You could download it. I think too, if you're in the club, there's access to the modifier presentation where I go into how to learn modifiers by family. When I very first started teaching it, we found that that was a really good way to understand it versus just going in numerical order. When you understand its purpose, oh, this unbundles things, or, you know, this is E&M only, or this is when there's multiple providers involved. So those sorts of things. What I'm showing on the screen right now is someone asked a question. What is, I don't know if that's too big. Yeah, there we go. The recommended way to bill same-day E&M services and injections so that both are reimbursed, including appropriate use of modifier 25, given that many insurers are currently denying E&M codes. So I'll look this up real quick, and here are the tactics to reduce current modifier 25 denials. So check your NCCI edits, put both codes in, see what it tells you. We use find a code, super easy to pop in 2 codes and see what the edits are. Make sure your diagnoses are supporting the E&M. Make sure you're putting the 25 on the E&M code, not the injection, because that is basically telling the payer that I know you want to bundle these 2 together, but this is a separate E&M. I have a significant history exam medical decision making, or at least medical decision making. So bill me for the E&M in addition to this procedure, even though the procedure is an injection. Yeah. I think a lot of times they think, it's like a nurse visit. They just gave an injection, and they're just, everyone's just checking off office visit, office visit, office visit, just because they came in. So they might be scrutinizing that and denying it, but appeal it. Because sometimes when you start appealing it and you get a decision, then everything will start to go through again. So don't just accept it, fight it. So you could read more. It's kind of a lengthy reply, but I did put the link so you can go see that on the Academy. And these are the kind of answers that we help vet. Just like everybody in the world, everyone's using AI, but we vet it. So make sure, and I just had a whole spiel that I did with we had an intern meeting, and I showed them all about AI because I took this big course about AI in business. And, people are afraid that AI is going to take their jobs. It's going to change our jobs for sure, just like encoders changed our jobs, but it didn't take our jobs. The company that I do work for, Solventum, we do computer-assisted coding or autonomous coding, which is basically using AI to suggest codes. So keep that in mind. We're just suggesting, our systems, our AIs are suggesting things, but ultimately we need to vet and supervise and bless whatever it says. So of course, if you're brand new and you don't actually know how to vet it, then you go click on the sources and you go look at, oh, this came from CMS. Now you start reading it and you're like, oh, okay, I missed that nuance. So that's how you use it, like an assistant, like a tool, but don't just think because it's very confident in the answer it gives that it's out of the box correct.
Yeah, Terry says, I don't see it replacing auditors either. Absolutely not.
No.
It is not foolproof. I use AI every day, and it's I can't even give it a percentage, but I would say it's 85% of the time it's spot on. But I'm not letting it do the work for me. I am letting it help me pull all the information together. Then I vet it, and then I pick and choose what I want. So, I was telling my father today, I said, it's like having Google on steroids. I said, back in the day, you wanted information, you pulled it off the encyclopedia. Well, this is the entire encyclopedia, not only in every encyclopedia in the world, and you get it in the snap of a finger, So, again, it's helpful. So what does that mean? Our role will morph a little bit, again, as it does all the time through the years. We'll become more auditor minded. That means because we're proofing it, and educating the physicians, the clinicians on documentation to make sure that we have all the information we need to translate properly. And then third, CDI. That's where the CDI comes into play. If we don't know the disease process and able to translate it properly, then it doesn't do us any work. So think of yourself as translating into a foreign language. If you want to learn Spanish, you're a Spanish translator. If you don't know the culture, as well as being able to translate the words, and the grammar and the dynamics and stuff, you really can't do an effective job, right? The same thing.
So before we part, we like to share a few things going on at CCO. We lots of questions tonight about CEUs. Yes, this one was approved for CEUs. They're available to the club members. We have a monthly subscription for $24.99, or you can get 2 months free over a whole year. If you sign up for an annual, it's $249. With that, you get the CEUs, you get all the handouts, you get continued conversation on the topic if you need more clarification, access to me and Alicia and the other CCO staff within the community area, and just the wonderful people in the community itself, including our interns. We have lots of good discussions, and it's not too much. It's just right. You don't get overburdened with 100 posts. It's just a handful every day. Very, very reasonable. Yeah, so if you're interested in the club, cco.us/club. And there's some other benefits with that. You get access to our Bat Cave, which has our annotated ICD-10 guidelines. It's got videos of exactly how to mark up almost your entire CPT manual, which is very helpful for certification prep and real-world coding to help you do comparing and contrasting to get the correct codes. These are the different prices. If you are also interested in learning, like taking a course, we have a lot in the academy. Many people are taking advantage of this Club Plus, where you get the club benefits plus 2 courses for $99 a month. It's $329 to get in and get set up, and then it's $99 a month, and you can take any 2 courses. You could try one and say, you know what, I don't, I was going to do pathophysiology, but I want to switch to pharmacology. And all you do is send us an email in your private support room. You get like concierge service, you get your own support room. And then it takes us literally minutes with this new platform. It's super, super easy and fluid. Our CDI course was mentioned tonight. We have completed Chapter 1. It's going to be 12 to 13 chapters, the whole course. We're hoping to release 1 per week. So come join us. We had, it's still going on, a founders package where it's 50% off. We'll never offer it that low. Couple more days. I think Mary said the end of the month, even though we hit our 50 founding students, we're still keeping it open to the end of the month. So your last chance, if you want to get it 50% off, it is a lifetime access purchase. You could purchase now and take it 6 months from now, a year from now. We will be updating it like our other courses as things change in the industry. So, and we've got a whole new system that we've developed for being able to quickly edit one slide if one thing changes. So yeah, check that out. I put the link in earlier to get to that. And it's fun. I'm enjoying doing it. And I know that's Alicia's world. She does that a lot.
That's right. It's awesome, guys. I really encourage you to jump in because it's foundational to our role as it changes.
Yeah. And just to let you know, this came up on a call today. Someone didn't know back in September, or actually, no, yeah, it was September. We went to either a lifetime purchase of a course, which is roughly around almost $1,500, or subscription for $59 a month. So you can rent it for $59 a month. If you can get through the course in 3 months, you just paid $59 times 3. That's it. If you want to check us out, but you don't want to commit to the full price, $59 is all you would lose if you decide, nah, it's not for me. Had a student on the phone today that was going to go with the AAPC, and I was letting them know, well, the word on the street is that they don't have the best support, and coaching is our middle name, certification coaching organization, and we are really good at the support, and our lectures are fun and not boring, and that's what we hear with some of the stuff with that. So and once you purchase with them, you can't get your money back. I don't think they have a subscription model. So we do. So give us a try, see what you think. We're open to feedback, but we do that even for people who have gotten stuck in a course they're not happy with, and they just are trying to get through it. They want to get to certification. Well, then for $59 a month, you can listen to our lectures while you're taking maybe the tests and with your other program, and you'll get the best of both worlds, or at least use our review blitz to help fill in the blanks and do that final review. Timed practice exams, that's the CCO proven process course, blitz, practice exams. And you'll do well on the real exam. YouTube. So I think that's it. So these are, pretty much every Thursday we're doing something at CCO. Once in a great while, we get a Thursday off. If there's five Thursdays in a month. So this is what we do. Come join us. We always have these live streams going on. If you want to be reminded, if you go to cco.academy, it says events. There's a nice calendar, and you can click on it, register, and you'll get the StreamYard reminders, and you can come in and chat with us here. But that's where you'll find me and Alicia hanging out at the CCO Academy website. We have it on our phones now. It pops up real easy. If we're taking a little break, we can go do, 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 and actually dictate an answer to whatever your question is. So we find we've been much more responsive on this new platform because it's more like instant messaging versus open up an email ticket, wait for a response. And it's a lot more fluid, less friction. And it's beautiful. It's pretty. It's fun to go take the course there because it looks a lot like, like social media. So,
right. This was a good question Terry had. Do you have a way to provide testing for AAPC credentials, or are students required to test directly through the AAPC? If you're getting an AAPC credential, they are the owner of the credential. They're the creator of the credential. So you have to test through them. However, we have practice exams. They do too. And we encourage you to take as many practice exams as you can get your hands on, especially vetted ones. And so we let you know who's been vetted, but absolutely, we encourage you to test multiple times with practice exams.
And there's, today we had a conversation with the student, and she was like, there's so many credentials, I don't know which one. And I said, well, basically decide which organization you want to be involved with. You could be involved in both. I was when I started, but that's because I was teaching. But there's AHEMA and AAPC are the biggies, and I call them Coke and Pepsi. AHEMA was around for a long, long time. AHEMA had a big emphasis in inpatient and the outpatient facility, like we talked about tonight. But then there was no support for coders that were working for doctors' offices. So this, I forget her name, but I remember the history. This lady who I think her husband was a doctor or maybe something like that, but she found the need and she started a little group and it grew. And then, but the difference is the AAPC is a business. They're not a professional organization in the sense how my American, I was an occupational therapist. So the American Occupational Therapy Association was not for profit. And it was, someone was voted in and it was, OTs for OTs. The AAPC is more of a business. They care about profit. So, AHEMA is more formal, if you will. Would you agree with that, Alicia? It's a little.
I call him the stodgy grandpa, and the AAPC is hip uncle.
Okay. Yeah. So, I kind of lean toward AHEMA. And of course, there's Q-Pro that the Innovi Health folks own. It's smaller. They purchased it from another company. Those are the
AMBA,
credentials. Huh?
AMBA.
For billing, yep.
They start out in billing and now they have a coding credential.
Yeah. So feel free to book a call with me. I'm happy to give you direction. It's cco.us/Laureen-call.
And reason that's important, guys, just another shout out for taking a call with Laureen, is because when she knows the right questions to ask you to get a feel for what you may not realize would be the best path for you, because been in the industry a long time. So as she, asks you these key questions, then she says, well, it really sounds like you're more degree driven. If you're, degree driven, then a HEMA is who would be really beneficial to you. And then, or if you want multi-credentials, that's your goal. AAPC has a lot, they've got more credentials than anybody else. And so you may want to align yourself with them, and so on, so again, if you just need a credential to change job positions maybe within, and they don't matter where you get it, then this other organization may be, a good fit for you because it validates your ability, but it's not maybe the most well-known credential, stuff like that. And we believe in saving you money and time. And
use your AI. I learned something interestingly because, I won't tell you the query that I used, but basically what came out about it was that our website about our inpatient credential wasn't, because the AI said, well, you don't have a course for inpatient. I'm like, yes, I do. And I said, oh, well, you need to change this and that and make it a little more clear. I'm like, oh, I guess you're right. And then I was asking the difference, with the AHIMA inpatient credentials and the AAPC. And it told me that the AHIMA one, people generally make 9% more with the CCS than the CIC. So those are little things, ask your AI, start querying it. Again, I'm not saying it's 100%, but check the sources that it shared. So I found that very interesting. So little nuances like that. And then someone was asking today about the CDI. Do I really need it? I'm doing, utilization or whatever. And I'm like, well, first of all, you can get it to try and get a job as a CDI specialist, or just to be more well-rounded in your knowledge. It's very, very interesting. It's not super hard. It's understanding, it's not hard to learn. What's hard is you have to be a very multifaceted individual. Like you need to know your code. You need to know the clinical, like the disease processes, where you recognize things like, oh, they mentioned linisipril. That's a blood pressure medicine, but I don't see any hypertension diagnosis. I got to query the physician. You can't say, hey, you forgot something. You forgot, you can't, there's a certain ways that you have to query, for legal reasons. And also because you don't want to get the physician mad at you. You want to have a good relationship, and you need to be able to convey things in a way that still respects, but you're still meeting the goals. And then you got all the financial people. So you're kind of like, as a CDI person, in the middle of these, these swirling things, and you have to be professional and juggle it all. And I was thinking the other day when I was working on one of the lectures that, it's a lot like being a parent, and you got 3 kids. You love them all, but they have different personalities, different needs, and you're trying to keep them all happy because you're in the same family, and that's kind of what a CDI specialist is. So us moms, we know how to juggle that. So
I think another thing to just shout out for the CDI is that we created this as an ancillary course. Although honestly, guys, it is really a lot of content. However, it's like taking the pathophysiology course we have or the pharmacology course. You need to build your knowledge base, and CDI is an ever-present part of what we do daily, whether you realize it or not. So why not go ahead and educate yourself in CDI, whether you decide to get a credential out there, and there's multiple now, whether you decide to do that or not, fill that knowledge base gap that you probably have. CDI is that important. It's just as important as pharmacology and pathophysiology and, those basics.
Yeah. Very good. Well, thanks everyone. Good energy tonight, and we'll be around next Thursday, and come join the Academy if you haven't already, and introduce yourself, and
come
we'll
and see what my hair looks like next week.
Yeah, right.
No, I may have a mohawk next week. You never know.
All right, everyone. Take care. Have a good night. Stay warm.
We appreciate you guys.
Bye-bye.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.